collaborating with ANACP, our dear friends from Chinese American Internal Medicine Association. And today we have three esteemed hosts. The first one is Dr. Yang, who is from Advent Health, Orlando, as a pathologist. Our second host is going to be Dr. Huang, who is our upcoming Mayo Clinic Florida faculties, rising star in the GI field. The third host is going to be Dr. Ni, who is at Mayo, Florida, as a second year GI fellow. I will give the control to them. Go ahead.
So should I introduce Dr. Wang? Should I go first?
Yes.
Okay, sure. I was thinking I can give you an opportunity to introduce the ANACP first.
Then you go first.
All right,
Sorry.
thank you so much. So I'm Dr. Yang. I'm a pathologist from Orlando, Florida. It's really glad to be here and have the opportunity to introduce ANACP. So ANACP is short for Alliance of North American Chinese Physicians. So this is a nonprofit organization established 2016. So as a family, we support physicians through education, knowledge exchange, and community service to achieve higher quality patient care and a better personal and professional life. And give me 1 second. So our vision is to be the leading Chinese physician organization in North America that promotes the well-being and professional development of its members. Thank you again to have the opportunity to host this lecture and welcome you guys to join this big family. Thank you. Now I give the spotlight to the real GI doctors here.
Thank you so much, Dr. Yang. So I'm Ting, and it's my honor to have the opportunity to introduce our speaker today, Dr. Xiao Wang. And she gave us very wonderful lectures inside Mayo Clinic, and I'm so happy that today she will be giving this lecture to the whole field. So Dr. Xiao Wang is an assistant professor in the Division of Gastroenterology and Hepatology at Mayo Clinic, Rochester. She is part of the consultative General GI group and also serves as Associate Program Director of the GI Fellowship Program over there. Dr. Wang completed her medical school at NYU, followed by her residency training at Emory, where she also served as a chief resident. She then pursued her GI fellowship at Mayo Clinic, Rochester. Her clinical expertise encompasses general GI with a particular focus on disorder of gut-brain interactions, or DGBI, such as irritable bowel syndrome, functional dyspepsia, and chronic abdominal pain. Her research centers on understanding the pathophysiology of DGBI and evaluating both pharmaceutical and non-pharmaceutical therapies, including hypnotherapy, digital therapy, and extended reality therapeutics. So please join me in welcoming Dr. Wang as she presents her cutting-edge talk, GI in the Digital Era, Apps, and the Medical Extended Reality. Welcome.
Thank you, Dr. Huang, for such a kind introduction. And thank you, Dr. Song, and our partners in ANACP for hosting this and allowing me to present some of this work and also some of my own work to share with all of you. Allow me to share my screen before I start talking here. Hopefully you guys can all see that. Thumbs up, 18? Yeah, okay, thank you. All right, so I will be talking about GI in the digital era because I think functional GI disorders may be a little bit less interesting to the general audience, even though they are very interesting to me. So I will start off by talking about currently available digital therapeutic options for GI disease. And then we'll move into talking about what is this medical extended reality, what is augmented reality and virtual reality, and why do we care about these uses in GI and other procedural or medicine fields. And then we'll identify some technological options and practical considerations should any of you want to implement this in your practices. But because this is near and dear to my heart, let us start with a case of irritable bowel syndrome, but not a patient case. We'll just talk about IBS. Because IBS is everywhere. And for those of you who are GI doctors, you know this. Even if you are a subspecialist, you cannot get away from IBS. It is in 10 to 15% of the US population. And IBD, in contrast, only affects 1.3% of US adults. And then only 40% of patients who have IBS actually seek care for it. And so it accounts for anywhere from a quarter to a half of all referrals to GI. And those in internal medicine will have a new diagnosis of IBS up to 1.6 times a week. For GI doctors, we are making a new diagnosis of IBS up to 5 times per week, unless you are, again, hyper specialized. This impacts our healthcare system with a direct cost upwards of 1.5 to estimated $10 billion per year. And this is direct healthcare costs, not accounting for missed productivity, economic loss, etc. And the reason for that is because our patients are suffering, right? Studies have shown that these patients who suffer IBS symptoms are willing to give up 15 years of life expectancy if we are able to cure their disease. And we as doctors underestimate how much patients are willing to pay, how much they're willing to wait, how much they're willing to tolerate side effects, as long as you give them a treatment that works. But the problem is, as many of you have noticed, we don't have a lot of treatments that work, especially not in the form of a pill. What we have that works, though, are brain-gut behavior therapies. And these are psychologically targeted therapies like cognitive behavior therapy, gut-directed hypnotherapy, and much more that usually take place in a psychologist's office, which is unfamiliar territory to many of us in GI or internal medicine. But in a network meta-analysis, these behavior therapies were shown, particularly CBT, either face-to-face or minimal contact, and gut-directed hypnotherapy were shown to be the best therapeutics for treatment of any DGBIs, particularly IBS. And DGBI stands for disorders of gut-brain interaction, or what we used to call functional GI disorders. And these behavior therapies, and it's not on this slide, but have a number needed to treat of 4. That means 1 in 4 patients who undergo these therapeutics have benefit in their IBS. This is equivalent to tricyclic antidepressants like amitriptyline or nortriptyline, but these behavior therapies have no side effects, unlike those anticholinergic side effects that we frequently see with our TCAs or other antidepressants. And so there's robust evidence supporting this care. And so why am I even talking about any of this, right? We've treated IBS, we found something that works. But before we get there, let me talk a little bit about hypnotherapy, which is a concept that usually is a little bit less known. And so I'll invite you all to come down this rabbit hole with me as I talk a little bit about why gut-directed hypnotherapy is of such particular interest to me and why you might want to explore it for your IBS patients. So the history of gut-directed hypnotherapy was started in the 1980s with a Dr. Peter Warwell out in Manchester. He used it as a treatment for IBS and found that with those 30 patients with severe refractory IBS, so at least a year not responsive to therapy, he saw significant improvement. And this was published back then in The Lancet in '84. But he showed that with that 12-week treatment session, okay, so patients did not continue to undergo treatment. With just those 12 weeks, those patients saw benefits lasting up to 6 years with improvement in their IBS symptom score. So this cured their IBS, essentially, right? And those long-term benefits included general improvement, with 83% of those responders doing well at 5 years. 60% of them were on no medications, and 42% were using meds less often. And here's the real kicker. 79% of them consulted their PCPs less often or not at all, right? This is the important part for us as healthcare providers because we are not just turning patients away, we are making it so that they do not need to seek healthcare for these issues anymore. hopefully I've convinced you that this sounds pretty good, right? Hypnotherapy, CBT. Again, why am I even talking about this? Well, CBT, these brain gut behavior therapies, hypnosis, they all generally are delivered by gut psychologists. So these are not only psychology trained individuals, they get subspecialty training in gastrointestinal disorders. The rough ratio of gastropsych clinicians to IBD patients in the US is one gastropsychologist for 18,000 IBD patients. And I told you at the beginning that the prevalence of IBS is 10 times higher than IBD. Looking at the number of gastropsych clinicians by state as of 2022, you can see that in the entire state of Minnesota, there are 5 trained gastropsych clinicians. They are all in Illinois at one of those big academic centers or in New York, right? And this is changing, and there are a lot more groups that are providing these services that I'm happy to talk about, but that's a little outside the scope of this talk. Suffice it to say, most of our patients cannot access one of these specialists. And you see a huge number of states on the left here where there are no providers that are able to provide these therapies that work so well for our patients. One of the benefits that came out of COVID is actually what's called PsyPact, where any psychologist credentialed in one of these blue states can actually do telehealth across state lines. Still some problems here. They're only limited to clinical psychologists, either a PhD or PsyD, and social workers are not available. And so there's a big cost differential there. These psychologists are expensive and again, not widely available. So this is why digital therapeutics need to be considered. The question is, in the era of digital medicine, apps, smartphones, can a digital product help meet this gap and provide effective care where we don't have the providers able to do so? But first, what is a digital therapeutic? When I gave this talk for the first time, that was one of the questions is, what is this word, right? And so I want you to conceptualize it in your mind as a pill that is now being delivered through a smartphone. So these apps are trying to take the place of a medication or a therapy session with a psychologist, right? So digital therapeutic is medication or some sort of treatment that is delivered via app. There's been some robust data showing that web CBT, cognitive behavior therapy, works just as well. I showed you in that meta-analysis, it was non-inferior to face-to-face CBT. And so based on this, a company called Mahana came out with a web product that is a gut-directed CBT app, 10 sessions delivered over 12 weeks. This received FDA clearance as a product that can be used to treat disease. And because of that, a prescription was required from a doctor. In a similar vein, remote gut-directed hypnotherapy saw a lot of benefit with similar results compared to face-to-face gut-directed hypnotherapy. Because of this, Nerva was the first gut-directed hypnotherapy app to hit the market. These are daily sessions, and they have not undergone FDA clearance. They didn't apply for it, and so no prescription is required. This is a direct-to-consumer product, so any of you could go to an app store and download the Nerva product today, pay a subscription fee, and try this out. And so that means any of your patients could do that. But the FDA agreed that remote hypnotherapy was a good idea. And so a company called MetaMe did receive FDA clearance for their gut-directed hypnosis product that was digitally delivered. This is a gut-directed app directing 7 sessions over 12 weeks. And because they, again, went up for FDA clearance, a prescription was required. We can get into some of the nuances here, but the FDA clearance really designates that they underwent robust clinical trial testing for their product, and the FDA approved it as a safe and efficacious treatment option for the indication of IBS. So this is Regulora. But IBS is not the only functional GI condition or the only condition where there is something called central sensitization, which is where patients experience pain more than they really need to. And the therapeutic potential of these brain gut behavior therapies or hypnotherapy or CBT for pain management is really vast and huge, which means that the digital versions of these should have vast potential as well. And so I tested this, and you'll begrudge me a little bit of divulsion of my own research here. And I developed a software treatment for reduction of bloating effect. And what we did was develop 7 sessions in conjunction with Dr. Oli Paulson at UNC, which incorporates both hypnotherapy and a diaphragmatic breathing technique, which is our one GI treatment for bloating that has been rigorously that hasn't even been that rigorously tested, but is now being more tested for abdominal phrenic dyssynergia and bloating treatment. This was a fully recorded, digitally delivered app at home. I sent them to my subjects every 2 weeks for a 12-week course, and they did a 3-month follow-up. And this was funded internally with a partnership through MedMe. We enrolled 25 patients, 23 of them completed, and one of them dropped out because their bloating was actually better by the beginning of the study. But what you're seeing here is that the severity of their bloating significantly improved by end of treatment. And at 3-month follow-up, the effect maintained, even though they were no longer participating in those hypnosis sessions. Their quality of life score significantly improved by end of study and then continued to improve at 3-month follow-up, though this was not statistically a huge jump. I'm sorry, this was statistically significant. What was not statistically significant is any change in their anxiety or depression scores. So hypnosis, right, and CBT was really not treating any sort of comorbid mental health condition. It didn't improve anybody's anxiety or depression. What it did improve, though, was what's called the Visceral Sensitivity Index. This treatment protocol improved the symptom-specific anxiety that patients developed around their bloating symptoms. And so what that means is, in a typical patient, when they develop these bloating symptoms, they start worrying, okay, what is this bloating? Is it cancer? Why can't I eat? The next time I eat, it's going to hurt my stomach. And then that sort of anxiety spirals, but it's all based around this symptom and around this condition of theirs. And so that's the VSI, and you can see that was an improvement that was statistically significant. Overall, patients enjoyed this. Most of them were either satisfied or very satisfied with the study, although we did have some patients who were not particularly satisfied. But the problem here is that, in the 3-4 years that I've been working in this area and trying to understand how to get this from my office into the hands of a patient, I've discovered that the big barrier is a payer. And so what has happened in the last 3 years is that of these 3 companies that I just introduced to you, the 2 that underwent FDA approval are now out of business because they couldn't get insurance companies to pay for their product. Nerva, because it is direct to consumer, is still in business and is now currently the only game in town. So what now? Other companies who are trying to explore this option have now taken a different approach. And instead of doing just CBT or just gut-directed hypnosis, they are now offering patients a more comprehensive experience and partnering up front with payers in order to deliver that. Some of those players are Able Health, which is a company that is, again, something that patients can sign up for directly with or without their providers' prescriptions. And what it gives you is a personalized nutrition plan. This mind gut program that combines that has some CBT components and also has some hypnosis components, a dedicated care team, and ability to track symptoms, right, and guide food options. So a dietitian, a psychologist, and a dedicated nurse all in one app. They showed that this app started out in IBD and showed that 81% of both IBD and IBS patients using this showed significant improvement in their clinical symptoms. Users reported better quality of life, and 90% were adherent to a program with a 90% average satisfaction score. So this is something that can be considered as what consider an off-ramp, right? Something to help your patients with their symptoms that doesn't necessarily require your office to be directly impacted or directly involved at every step of that process. Other apps taking this option, one of them is called Trellis Health. And this uses, this is Lori Kiefer, who is one of our big names and prominent members of the field in terms of GI psychology. She developed this based on the Resilience 5 model of disease acceptance, and then how do you live with your chronic illness. This is targeted towards IBD patients. and showed that of the patients that they tested, participants had a greater reduction in their healthcare utilization than non-participants, with 71% reduction in ED visits and 94% reduction in unplanned hospitalizations. That's huge for an IBD patient. They reduced their requirements in opioid use as well as steroid use in the groups that did participate, and they had higher resilience points, meaning that they were able to live with their illness. But the key to Trellis Health is that they serve health plans and employers. They do not serve patients. And so the way that this app has kind of financially pivoted is that they partner with employers, with health systems, with pharma to offer their app almost as an adjunct to maintain their IBD patients instead of targeting to IBD patients alone or directly, because again, there's a payer problem in this field. Let me tell you about some of the other digital apps being used throughout GI, and this is some of the work that's either been published or is being worked on. So there's an app out there called Dieta Health, which helps patients kind of monitor their fiber intake, their GI symptoms, and actually has an AI-based algorithm to take a picture. They have patients do a daily stool image capture, and then it can actually grade it using AI to say what the Bristol stool scale is. And so, one of my colleagues, as well as a colleague at a different institution, used this app to see, can we use Dieta to titrate lactulose, such that if the stool wasn't soft enough or the patients weren't having enough frequency of bowel movements, the app actually alerted them to take more lactulose in this instance. The other app used it to manage hepatic encephalopathy. So using the scale rather than just a bowel movement number actually helped patients reduce their lactulose dose so that they weren't having kind of too many bowel movements, which is also a problem in patients who already have encephalopathy issues. And show that patients were pretty comfortable with the app. They were pretty willing to take pictures of their stool, and that the dose adjustment when AI generated was pretty reasonable and had good correlation. If you guys are interested, there's also a product out on the market called the Smart Toilet, which may or may not have, it actually was famous enough to make it onto the Colbert Report as almost a joke. But it's a toilet that's able to do what this app does in an automatic fashion and actually time when the stool lands, what the quality is, and they're developing other features, including attempting to sample the stool as it is dropping to analyze the microbiome. Very interesting stuff. The RIA platform is a digital application that's similar to what I kind of described in Able Health, but specifically for alcohol-associated liver disease patients. So patients sign up via the RIA Health website, and they basically help give you physician guidance, medication options that reduce cravings, coaching support, and digital tools. What's also interesting is that there's a Bluetooth link breathalyzer so that patients can actually assess and report their alcohol levels. Now, whether or not they're willing to do this is a different question, but it is an available option via this platform. Their outcomes show an average of 70% reduction in alcohol use over 12 months, and average of 55% of patients are staying engaged. Mayo has a cirrhosis remote monitoring program as well, where patients who are hospitalized with decompensated cirrhosis get enrolled at hospital discharge, and then they get sent home with all this equipment so that nurses can monitor the data alerts in real time. So a lot is still being worked on in the digital health space, but a lot of consideration needs to be given to how we're going to get these apps to be financially viable enough to actually help patients in the long term as well as our practices. So switching gears a little bit, I'd like to take you guys with me into what's called the metaverse. And we're going to talk about what is medical extended reality. So as an overview of extended reality, this field or this term encompasses virtual reality, which is where you're wearing this this headset and you are completely in a digital environment. Augmented reality, which is kind of a real world experience with a digital information overlay, best embodied by the very popular game Pokemon Go, where you could shine your camera on the phone and on the phone you saw the real world, but now there's a Pokemon in front of it. or merged reality, where those two things become intertwined, where you could have a real and a virtual component and interact with both. Why are we talking about this though? What is the point of talking about a gaming platform in the medical field? One, because I love video games, but two, because it has a lot of general applications in patient care management as well as education. And we're going to talk about a few of those management options. In endoscopy, which is my particular area, right, of interest, we implemented VR in a pre-procedural setting because pre-procedural anxiety increases patient dissatisfaction. There's a potential increase in sedation needs, an increase in intake time because patients are so nervous that they keep talking, or they're not able to get an IV, and generally kind of adds to the overall high stress of an environment that does not need to be stressful. Needle phobia is a big concern for a lot of patients, and so what we did was launch a trial of VR in the pre-procedure space. Patients were offered the use of this handheld VR device prior to their endoscopy. We looked at their anxiety inventory score before and after VR, as well as their vital signs. We did this over the course of 6 weeks in 39 patients who were willing to undergo this study. About half of them were women, mean age of 48 years, and most of them underwent colonoscopy, though some did EGD and some did both. What you're seeing here is a decent amount of psychiatric comorbidity, and a lot of them were on no medications, but some of them were on SSRIs or benzos or other anxiolytics. And what you'll see here is that most of them underwent endoscopy without any issue. And the very bottom portion of this shows flagged for anesthesia in the future, which means they did not tolerate that sedation well. And only one of those 39 patients were flagged for future anesthesia. We saw a significant improvement in their anxiety scores before and after VR use, as well as in their heart rate. We asked them for their qualitative feedback, and a lot of them really loved the experience. They thought it was very calming. But most pertinently, and the most positive feedback was around not having to pay attention to the IV insertion, which was very interesting. And so we're going to be implementing this, especially for patients who have that needle phobia or are a difficult stick. But what about using it inside the colonoscopy suite? We haven't done that yet, but can you do sedation-free endoscopy utilizing VR? A study in the Netherlands stating as early as 2020 did this with 19 patients, and they showed that patients accepted it and did pretty well. So 9 out of 10 of the patients rated the glasses positively. There's no significant difference in comfort or anxiety scores, and no difference in how long it took the provider to get to seek them or complete the procedure, or the amount of sedation patients eventually needed. In Shanghai, at Fourth People's Hospital, Liu et al. Did this in 117 patients, and patients were either given VR with a headset or just headphones without sound. So the proceduralist was actually blinded because all the patients looked the same. And you can see that the colonoscopy time was was almost exactly the same, with the VR patients having a little bit shorter procedures. Pain scores were very much improved in the VR group compared to control. And again, these control patients got nothing, right? No sedation. And skin conductance scores, which measures kind of distress, was much lower in the VR group. In a US-based population in 2021, Mass Gen put out their study of 27 individuals undergoing colonoscopy. All of them started with VR, but they had the option to opt out. CECUM was reached in all cases, and the majority, 26 out of those 27, completed without any pharmacological rescue. Procedure times were comparable, there was minimal pain, and the endoscopists were happy, right? The overall time was similar versus the baseline average procedure time, and the overall experience was really good. There are many companies that can provide a product that is acceptable sort of for putting patients to sleep. And this is me at one of the VR conferences trying one such product. And don't I look so extremely comfortable, right? So what else can you use it for? Chronic pain management is where a lot of this started. But inpatient pain management, I apologize, chronic pain management is what I'm interested in. Inpatient pain management, acute pain management is where a lot of medical VR really started. And so this was a relatively old study published in 2017, but the work had been going on much longer prior to that, looking at using a game within the VR system to manage inpatient pain. And they saw that in the 50 patients who got VR versus those who just watched a two-dimensional distraction video, um, 65% of the patients in the VR cohort had a pain response that was reached the threshold of acceptable pain reduction, compared to only 40% of the controls. And there were no adverse events reported from VR. Dr. Brennan Spiegel is now working along with some of our colleagues in Mayo, Florida, at outpatient pain management in the functional GI space with this robust experience of a virtual clinic where patients can learn about their IBS. They can undergo these education modules that they're able to interact with. They can undergo an urgent care, which is more of like a guided breathing, an acute pain distraction area. And there's actually also this experience of exposure therapy, where in VR, patients are taken to a bathroom and then they're kind of guided and directed so that they can kind of change their experience around toileting and kind of their fear and anxiety around the process without experiencing physical pain. In the functional dyspepsia space, kind of a little higher up in the GI system, Dr. Ken Jemmy, one of our colleagues down in Mayo, Florida, did a randomized double-blind pilot looking at VR versus sham and showed that the VR group did have significant improvement in their PAGI-SIM, which is a patient-reported outcome score, and one patient withdrew due to adverse effects. Other areas VR can be helpful is in rehab. So you can see here a patient kind of in the hospital bed, right? Imagine this patient kind of moving more because they're now put into this VR system where they have a foot pedal that gets implemented, and what you're seeing on the right is actually a picture from a conference. And within that VR headset, what that lady is doing is she's actually pedaling with her feet, and the movement from that device, it's almost like an under-desk elliptical, is being fed back into her VR headset so that she's moving in VR and she's using her hands to kind of pop balloons as she's moving. Really fun experience, but I will tell you that one gave me significant motion sickness. What patients can do instead is different types of experiences, including dynamic breathing, mindful escapes, pain distraction, to help them move their bodies more than they would at baseline, right? So VR is a motivation tool. Within the education space, the potential for VR is extremely vast. So this is a little bit of a projection in a future, but imagine kind of walking into a patient's room, right? And then being able to see all of their vitals on your headset, their latest labs, their current vitals, and then record a new examination so that you don't have to chart it later, right? So that's sort of a potential for actual patient care, but we can do this already in simulation. And you can interact. What you're seeing here is that these medical students are all standing together in a room, right? And they're wearing these headsets that projects this holographic patient in front of them. And they're using this 3D video capture of this professional actor to work through a case of anaphylaxis. Simulation training can be used for CPR, for learning how to insert an ECMO line. This has been used a lot in the pediatric anesthesia space, for example, because peds anesthesia, you don't want real life situations to practice on, right? And those situations where a child decompensates in the OR are so rare and far between that they're not good for practice. But you need those anesthesiologists to be well trained for those scenarios. And so instead of doing an OSCE or a simulation over and over again where you're paying an actor, why not do it in virtual reality, where you could do that at any time, any space, as many times as you want, until you have that familiarity and competence to manage an actual real life situation. And this technology has gotten really great to the point that this is someone putting in an IO line in VR. And when you press on the bone in virtual reality, the receivers actually send you feedback to that buzzes differently, whether your needle has hit bone or whether your needle is still penetrating skin, so that you're actually receiving some sort of real-time feedback as to whether you're doing this procedure correctly. This system is even more advanced beyond that. So this system is called GigXR. And what they're doing is they have simulation in a multi-step approach. And so first you learn how to do, this is an IV insertion. So first you learn it in virtual reality with fake equipment that you're picking up holographically in midair. But then what GigXR is able to do is have the real equipment set up just like this fake equipment. Like you can't even tell, right? This table is real. That arm, the IV, the tourniquet, all of that is real. But this tourniquet on this table on the right with the blue sheet is actually a hologram. And if you set things up correctly and then tag each item, then there's a virtual trainer that's able to walk you through your physical movements on the real stuff. So it'll tell you pick up the tourniquet. And when you successfully pick up that tourniquet in real life, it checks off a box. When you tie it onto the arm at the right spot, it checks off a box. When you prime your saline correctly, it checks off a box, etc. And then you can either practice on this real mannequin arm or this simulated patient. And what you're seeing is what he's seeing in this virtual reality goggle, right? And so this is what's called mixed reality, where the audience is right in front of him, but he's projecting this holographic patient that he's able to interact with, or he's interacting with that actual mannequin arm. Hard to explain from a picture, but hopefully you guys all followed. Think about interactive anatomy. How many of us, right? Most of us, I think, in this room trained on cadavers. And those cadavers were not standardized, and you couldn't really see how things moved, right? Or structures. And if you severed a nerve, well, it was gone, right? Now think about medical students learning an interactive holographic anatomy that they can now project in front of them. And now they can turn this heart around. They can open up a valve. They can see how things flow, all without kind of having to do any of the dissection work, which we could argue loses something. In the operating room, VR has multiple uses as well. On the left is a lot of companies have now been able to re-image, restructure using a CT scan patient anatomy so that it can overlay it onto the actual patient in the OR and help guide surgical procedures. On the right is a virtual reality designed graphic of patient that this surgeon is about to operate on so that he can see exactly what those vessel structures look like before he opens the patient up in three-dimensional space as opposed to reviewing it on a CT scan. There are many simulated patient experiences where you can practice individually or in multi-participant scenarios so that everybody's in VR interacting, providing CPR, doing all the same things so that you can practice team-based work as well. Communications and empathy training is also a big area that we can use VR for. Looking into the well-being area, this is one of my good friends who is my guinea pig every time I want to test a new toy. Employee wellness. So this Hoag Center in LA is a private group that gave all of their nurses VR sessions at home, 4 to 6 sessions. 80% of those nurses experience stress reduction and 43% reduction in stress on average. So it helps and it can help maintain employee wellness. And this is something that's being tested across Mayo as well. We in GI with a nursing group use it for upstander and empathy training, where here you're actually, when you are in VR, you can do something called embodiment. And so here, when you are loaded into this experience, you're told this is you, this is your reflection, and this is my. And as you move your arm, she moves her arm, so that there's a little bit more kind of belief that you are this avatar. And then you go into these experiences, and you, as this individual, watch as other people experience microaggressions or microaggressions are targeted towards you. And the experience allows you to identify the bias and then try to work on responding to it. Many of our trainees who went through this found that they were more willing to act, right? That they were more confident that they can speak up when someone has acted in a biased way or they have more intention to speak up. But what you can see is not all the trainees felt that way, and some of them were less likely to speak up, or they found that they were actually less able to speak up when actually faced with a biased situation. So instead of just talking about microaggressions, right, we can actually put people in those scenarios and say, can you do something? Are you ready to do something? And if not, can we train you to do something next time or when it actually happens, right? So huge implications across the spectrum of medicine. But what about implementation? So like you're like, this sounds great. How do I actually make it work? There's a number of hardware options, and in what needs to be considered is really what you want to use it for, what systems are important to you. And for me, what was the most important is getting rid of these handheld controls and using something like a kiosk or a tablet so that you can control the experience without having to point and click. Because if you have to point and click, that means the patient or whoever is using this device has to learn how to point and click. And that is not an easy feat for a lot of our patients and trainees alike. What are some of the options available? So the Meta Quest is now on the Meta Quest 3 or the Quest Pro. Pico has a system, and the HoloLens, the Microsoft HoloLens, is a system that does both virtual reality and augmented or mixed reality. So when I was showing you the holographic patient, all of that goes through HoloLens. And this is the latest rendition, which is HoloLens 2. And then, as everybody is probably well aware, Apple came out with the Vision Pro, which actually has a lot of downsides that I'm happy to chat about. With those considerations, what you're seeing is that the Meta really requires a Meta account, and all of the data runs into the Meta cloud. And so there has to be some considerations for patient safety if that's what you're using it for. The pros of the Quest Pro is really eye tracking features, which means that the patient can control their experience, or whoever's in VR can control their experience using their eyes and not using those controllers. With the Pico 4, all the Pico systems come with eye tracking, and the 4 Enterprise version is just a lot more bells and whistles. The HoloLens 2 has AR capabilities, but no controllers. And the Vision Pro has both AR and VR capabilities, has amazing graphics, but the problem with these last two is that they are individualized, which means that each person who wears the headset needs to go through a calibration process, which can be lengthy and can be off-putting if you're trying to use it in a high throughput environment. There are a lot of software considerations as well. There's a lot of off-the-shelf products for all of the indications I mentioned just now. You can go out and buy any of these today. There are other systems that are considered all-in-one, right? That come, so those software products, you buy your Pico headset, you load the software, and you can use that. And then when you're not using it for a patient, you can play Beat Saber or some other game. But the all-in-one systems only come with their embedded software, but are easier to use. That means when you turn it on, the system that you're looking for, whether it's rehab or pain control, is already loaded, and that's the one that's going to run. It's easy to use, but you can't use it for anything else, right? So that's the con. And then there's a lot of platforms, and any of these companies are interested in customization or development. The question is at what cost and to what benefit, right? But with the right partner and the right vision, any of these companies are generally open to talking and working and collaborating with you. The future is here, but the future is advancing very rapidly. Let me show you two of the amazing things that are on the market now. This is called the haptic glove, and I got to try one of these. It's really amazing, actually. You put on this glove, and then you put on a VR headset. And with this glove, you can actually grab things in virtual reality to the point where you can grab a piece of paper and feel the response as if you are kind of, it doesn't feel like you're grabbing paper. But even with something so thin, you know exactly when you've hit the mark that you're trying to hit. And you can think about how useful this might be for something like surgical simulations or procedural simulations. This is an AI-based psychology or AI-based psychologist, and this robot actually talks to you with an AI-generated kind of like ChatGPT in a robot form. And again, I tested this robot as well. And I mean, I'm telling you, she's as good as a real therapist. Probably not as good as the best therapist, but probably as good as your average therapist. And you're able to kind of pose all sorts of questions to her. She thinks a moment and gives you some pretty reasonable responses. And then she's able to change your background to match your mood. So if you're not feeling well or if things are getting a little bit heavy, she can actually change the tone so that you're really experiencing and immersing in this it's an immersive experience. And this is developed by Brennan Spiegel and Omar Liron's team out on Cedars-Sinai. And then this last thing I just cannot believe is actually available. This is called Blink IT, and this is a contact lens. So unlike Google Lens, where you had to wear it outside and it would give you information about your world, this now you wear on top of your eyeball. The signal is sent via the sticky piece of equipment above your eyelid and fed out via wireless, and don't know what happens to the data. I have not tried this. Not sure if I want to, but this is available and in development. So in summary, Medical extended reality encompasses these three components, right? Augmented, virtual, and mixed reality. And the use really spans education, either for trainees or for patients, clinical treatments, especially for rehabilitation and chronic pain, procedural support, and employee well-being, among many other uses. But your implementation needs to consider your indication and you have to match your hardware and software options. Digital therapeutics also have a role within our clinical care. But again, the future of digital therapeutics really depends on what direction payers are going to go in and whether patients buy into kind of use of digital support and AI. And as AI becomes more robust, AI generated care for their health. So with that, hopefully I've left enough time for a robust discussion. I will open it to questions and answers, hopefully.
Yeah, thank you so much, Dr. Wang, for this wonderful speech. I have the opportunity to review the slide. I think it's a great talk, especially for the patient we deal with every day. They're very excited to know there's so many upcoming technology to be able to assist the patient in our patient care. I think there are two patients in the chat right now. There's a Dr. Lu. She is asking how well do the insurance cover this prescriptions?
Not well. So the reason why both Mahana and Regulora went out of business is because initially they were able, oh, let me actually stop sharing. I apologize. Initially they were able to get some payer support, and it was kind of a lower rate, but um, I don't know what the holdup was, but eventually they weren't able to get most of the big payer systems to actually cover any of these apps. And so then patients were paying anywhere north of $400 out of pocket per month for these therapeutics, which for most of our patients is very prohibitive. And so their companies kind of were not financially able to maintain. With Able Health and a lot of these other companies, they actually went directly to the insurance companies and said, we will partner with you and we will take on your patients that you cover. And so there's another company that's whose name is escaping me right now, who I spoke to, but they partner with large corporations like Target, and they offer it basically as like an employee benefit. And they kind of get paid that way so that it's covered for the patients, but they don't need the FDA, they don't need kind of big insurance companies to be involved. With Trellis Health, they just didn't even market to patients, right? They marketed directly to payers and said, I can reduce your patient costs by reducing hospitalizations if you give them this app, right? You sign a contract with me and you provide this for your patients. And so people are getting creative. Um, the FDA recently also approved a digital app for depression. And there is some hope that because that one is owned by a bigger pharma company, that they can have more push with payers. And if basically they just need one payer to sort of sign on, right? They need Medicare, Medicaid, or someone else, Blue Cross Blue Shield, to take up and say, okay, we will cover digital therapeutics as an option. And then the rest of the apps are sort of waiting to see where that goes. Because if that kind of opens the gates, then they're more able to get other ones covered as well. So there's
Yeah,
some hope, but that's a little bleak right now.
yeah. Thank you for answering that. There, Dr. Song have a question. May I ask if there is a VR simulation platform available for scope practice?
Currently, no. If I have anything to do about it, maybe in 5 years, yes. But that kind of platform takes a long time to develop, and I've talked to actually a few companies about this, and the physicality of scoping, right? Those of you who are GI doctors on this call know, like you can play with a simulator all you want, but until you scope the loopy colons, you're not gonna your skills are not going to advance, right? And so how do we simulate that? The haptic glove has a lot of opportunity and a lot of potential. But to get that right, to get that feedback right, to get that feeling of loop reduction correct, right, takes a lot of nuance. That there are some companies who are very interested in developing it, but the question is it going to be worth it, right? Because ultimately, a GI fellow will scope patients. And so, how beneficial will developing this like 100,000, it will cost at least $500,000 to develop such a simulation. And the question is, will you recoup that cost, right?
Yeah,
Practicality.
yeah. When you talk about the pediatric anesthesia using those like simulations, I was thinking Because sometimes we also have those situations like food
Mhm.
impaction, very rare cases, volvulus, those things you only take when you are on call. And
Yeah.
sometimes rare, it's a hit or miss. It might be very useful if those can be designed in the future for practice.
Yeah.
Oh, there's another doctor. I have a question for what's the mechanism to treatment for IBD improvement?
Yeah, great question. So there, it's a little bit debated, but I assume you're asking about kind of the Trellis app and using things like CBT for IBD improvement, right? And there's a known correlation that stress can induce an IBD flare. That anxiety, the stress of life, or illness, right? Any of those things kind of activate our cortisol system and can lead to deregulation and kind of flare of inflammatory bowel disease. And so the thought behind CBT and hypnotherapy is actually to regulate the patient to not react to some of those anxiety triggers, to be able to manage their own stress better in an externally stressful situation. And from that, this app is not going to prevent C. diff from flaring ulcerative colitis. And hypnosis is not going to be as good as an anti-TNF, right? That's not what these apps propose to do. But what they do propose is that when your IBD patient has a stomach ache, that they're more able to sit at home and maybe try a couple of more exercises, breathing techniques, etc., to see if they can control the pain before going immediately to an ED, which is where potentially they'll catch C. diff, right? And so kind of using self-resilience and tolerance of pain to then turn down the anxiety and actually decrease pain signal is what some of these apps and the gut-directed therapies are meant to do, or brain gut behavior therapies.
Yeah, I absolutely agree. A lot of people have IBD, especially Crohn's disease,
Hmm.
have chronic pain management
Hmm.
problems.
Yeah,
And then a lot of those, if the VR can help with the anti-anxiety or just decrease visceral sensitivity, I think
yeah,
that will be a much better utilization of the emergency room and also our medical care. I have a question.
absolutely.
All the audience, feel free to ask questions in the chat or feel free to unmute yourself if you want to talk, you want to speak. I have a quick question. When you talk about hypnotherapy, there is only 5 hypnotherapy providers available in whole Florida, and we have been trying so many years. I heard that my program director, Dr. Lacey, have been trying to recruit hypnotherapists for so many years, and we can't even find a one. What do you see that we gain access to hypnotherapy in the future? Like, do you see a GI doctor, especially functional GI doctor, taking a role on those hypnotherapies?
Yeah, good question. So, Minnesota, so within 200 miles of Mayo Clinic, there are 3 hypnotherapy providers, and I am one of them. And I will tell you that the training to be able to do hypnotherapy, particularly gut-directed hypnotherapy, was amazing. Was one of the best trainings I've ever taken. One, because of the hypnosis as a tool, but two, because you learn how psychologists talk to patients about their pain and teach them how to manage and live with chronic pain. And that was such a useful thing for me to have learned as a GI doctor, right? Because we manage chronic pain so much. It is not useful or practical for a GI doctor to do hypnotherapy. It is time consuming. It is so the first part of the point is that anybody on this call could become licensed to do hypnotherapy for medical issues. Anybody, as long as you have a license, there's a society called ASH, or the American Society of Clinical Hypnosis. As long as you have a medical license, they will train you to deliver the therapy. So that's one thing. So I would recommend, Dr. Lee, that you just do it and don't recruit people. Just teach the people who are already there and support them to go through the training. It's actually a pretty fast process, 40 hours, and you're pretty competent. So it's two 4-day workshops. Um, but to the second point, right, you kind of have to think about what's worth your squeeze. And so my time is very expensive for my institution. And so they would rather me be doing colonoscopies and not, maybe I shouldn't say this in a recording, right? But that you understand, right? I want to work at the top of my license. And so delivering hypnotherapy, which is often scripted, does not really require me as a physician because I don't do medical decision making during that hypnosis session. I still provide it for my patients because they have nowhere else to go. And so I can take on a couple of patients at a time. But I do this often outside my clinic hours. And so the most practical way is really to train kind of mid-level clinicians, APPs, RNs. And the way our pediatric GI practice has made it work is they've trained, one of their APPs got the training. And she has such a robust practice now that kind of all of the peds referrals go to her. And so, and that's a model that has good financial balance and also provides the right level of patient care, right? And so those are all things to think about. Yeah.
Yeah. Thank you so much. Those are very exciting news. Thanks for sharing those
Yeah.
tricks. Anyone else have questions that we can ask Dr. Wang? Okay. Dr. Song, is there anything else that we are planning, especially for our society?
Yeah, Dr. Wang, I wanted to ask you one question. By the way, great talk.
Thank you.
So as a GI motility specialist, I saw a lot of patients with functional dyspepsia, which is basically patient complains stomach pain, but we can't identify any ulcer inflammation. It's a chronic disease, lifelong, unfortunately, symptom-wise. So I was so amazed by the picture. You were lying so comfortable in bed with extended virtual reality. That was amazing. One of the questions I have, because I saw those patients when they get in treatment, they may feel not so excited
Mhm.
uh, during their follow-up because of a lot of therapy, they do carry only
Mhm.
marginal effect.
Mhm.
So my question to you, how we are going to engage with those patients with lifelong disease in a chronic fashions, like chronic illness management.
Mhm.
What's your thought? I know it's in emerging therapy, very exciting, by the way.
So two things to that. I find that patient population, I know we were chatting about this before, but it's a challenging patient population because we have very few therapeutics, right? There are no FDA approved medications for this disorder, and yet it impacts, 30% of our GI population up to kind of high in the high range. Um, so Sarah Kissinger is a gastropsychologist out in Chicago, and she and Ole Paulson have developed a hypnosis protocol specifically for functional dyspepsia. They were undergoing trials and they were going to license to Medime, and then Medime went out of business. And so there is still a protocol out there that can be used, and any trained hypnotherapist can have access to it through them. They're very good about sharing that, but it needs to be delivered to a patient. David Kangemi and Brennan Spiegel are, along with Dr. Brian Lacey, they're working on developing a VR protocol to treat functional dyspepsia specifically, similar to their IBS treatment, so that there is that education component and then also a management component. But the baseline of all of this and the root of this problem, as you mentioned, is really patient acceptance, right? That this is a chronic illness and that even though there is no kind of um, ulcer or CT finding or cancer, that they have pain that they must learn to deal with and live with. And what I have found is that, and this is sort of part of the talk that I did not give, is that trying to get that patient buy-in, that market, that I know what you have. You have functional dyspepsia. I am certain of it. And you must be certain of it too before you're going to get better. And when the battles that I lose are the patients who won't believe me, who need to see the fifth specialist, the seventh specialist to find the ulcer that nobody else has found yet, right? The ones that believe me and believe that I know what they have and that they have functional dyspepsia and that I can make it better. I may not be able to make it go away, but we can together make that better, then they get better. And so I do feel that the buy-in that patient belief and in your alliance that you will help them through this and their own kind of willingness to take on their chronic pain and learn to live with it and live through it, right, is very, very important. And so I spend a lot of time just trying to get to that point. Forget the treatment. I just need you to believe me that I know what I'm talking about. And so I tell my patients I've learned I need a marketing degree.
By the way, thank you so much for such great talk and doing pioneering work in this field, very exciting field. Dr. Ni, do you have anything else to add? Otherwise, we are going to end this session if there's no additional question. I saw Dr. Huang, one more questions. Ask, what about AI? Will AI be able to help with providing hypnotherapies? Is that question already been answered or no?
No, it's a fair question, and I'm gonna say no. And I'm gonna say that yes, it can help, but um, this is an area where you need not artificial intelligence, but human connection, right? It's that marketing, it's that therapeutic alliance, and there is an area kind of where AI just doesn't have the same buy-in. And part of the reason, I saw really good response in my pilot trial. And I will tell you it is because I will admit this on a recording that I know how to maximize a placebo effect for hypnosis, right? That if my patient believes me before we do hypnotherapy, it's going to work a lot better than if they've never met this provider and it's just being told to them that they should listen to a recording, right? When you take the time to explain why, et cetera. I think an AI is able to deliver education where education is not available, and there's a huge role for that. But there is something about a human connection that needs to happen in these DGBI care, and AI is what it's missing a little bit of that. And I will glibly tell you that I'm in this field because I don't understand AI well enough to be working in that. Exercise is very helpful for the brain-gut axis. Movement therapy has really good evidence actually for improving pain, right? From a number of standpoints, and I could talk about that for a very long time too. But definitely exercise is helpful, both in kind of engagement and also in activating kind of body function, right? And particularly, there is good evidence for what's called meditative movement. So not just walking or running, but like things like yoga, like qigong, actually Tai Chi. There is data to show that these types of movement where your mind is actually centered and you're paying attention to your breathing in your body, those have better effects for DGBI care. And there's a lot of people studying those in particular. Also why I love this field because a lot of importance for acupuncture, for complementary alternative therapies, for traditional Chinese medicine, all of those have been studied in IBS and have some hope. Yeah. I'm happy to stay on and answer questions if you want to, Dr. Song. I want to make sure that others can get to their evenings.
Excellent. I think we already 5 minutes over the limit. I think it's fair, just call it end for the
Yeah.
meeting. But again, thank you so much. Great job. Thank you, everyone, for attending our meeting. Have a great night. If you have any further questions, welcome to reach out to any member of us or directly to Iris, and definitely we will get you back with the answers. Thank you. Have a good night.